Hello, everyone. Good afternoon.
Good afternoon po, Doc.
Hello, Bettina, Kurt, and Leah. We're missing a few members. I wonder if they're already here. Are you? Did they message you any technical difficulties for this afternoon? Maybe power outages or internet problems, Bettina?
Ah, Doc, so far, wala pa po nag-message sa akin, but I'll try to reach out to Edita po.
Okay. Sige, sige. While you're at it, again, one pleasant afternoon to all of you. It's a little cloudy where I am at. Probably expecting rain. The weather's getting cold, so it's nearly Christmas. It's a very unique Christmas this year. I guess all of you will agree. So, this afternoon, we're going to have our Decury regarding your assignment on the POMR, which incidentally was assigned to you a little while ago. So, I don't know if you guys still remember or if you already made your presentations much earlier aside from the assigned date. That's okay. We're going to take a little bit of review, of course. And what I noticed, there's a lot we'll need to discuss, especially on how to present your actual or written outputs. So, in the meantime, let me just flash my slides while we're at it. The competency required for you today is, of course, to come up with an appropriate assessment this time. So we've done all of the physical examination, the history taking, but there's still some room for some editing because I'm sure some of you might have commented a little regarding this protocol of ours or our clinical history. It's lacking in several items. So maybe we'll go across some of those that we might need to correct or add on, or maybe some stuff that you detected that were also amiss. So the second part, of course, is to draft an appropriate and comprehensive plan this time. So our P or our plan is now divided into your diagnostics and therapeutics according to your clinical assessment. So I would like to emphasize again and again, and you'll see this slide many times today. I want you guys to know these clinical pearls, or we will call them key points, for our lecture or Decury session today. The first one being your diagnosis is only as good as your database. So the database is S and O, of course. And then your assessment should be correct based on those so that you will come up with an appropriate or the best plan. So remember this as we go along. So in terms of the point distribution, the scoring rubric was also given out or handed out to you in your earlier slides. I don't know if you still remember, but we'll just pass through it today. So the assessment scores being divided into the components of your assessment, the basis of your assessment. So here's where the S and the O items will be entered. The differential diagnosis, there should be at least two. Now, I'm going to give you a tip later if in case there's no other differential diagnosis you can think of, you can actually tweak it a little. So just a preview on that. Now, if you'll see, the assessment as well as the differential diagnosis consists of a defense. We'd like to know how you arrived at your diagnosis or how you ruled in or ruled out your differentials. So how you exercise your mental faculties, your reasoning, your stock knowledge, your extensive readings in order to reach a diagnosis will be assessed. And eventually, later on in the second session, eventually be graded. Because today, it's completely an exercise. So I would say you can all relax for the meantime. So this will not be graded yet, but maybe I would add on the group score for your participation and some additional points if we ever come across any. So again, the next components in your scoring rubric are your diagnostics, how complete they are and how appropriate they are, and also with regards to your therapeutics. So remember that you have two itemize the drug of choice specific to the case. So here I am again saying to you that your plan should be relative to the specific diagnosis. So, even if you have the decahon or routine laboratories, but your clinical case doesn't merit it because of certain intricacies or uniqueness, then ibig sabihin, you might be different in your course away from the ideal. Okay? So again, the rest of the therapeutics are going to consist of the supportive management as well, and patient and parent education. And this time, we'd like to practice ourselves, and also we'll already try to master the so-called empiric doses and computed doses. So we're going to learn more about that also in today's session. So all of that supposed to be 40 points, but again, as I said earlier, not yet to be graded today. That's the bilin of Dr. Gomez. So this is going to be an exercise. So, as a reminder, not all of you might have had the same diagnosis, and that's completely fine because we're trying to say that there is no one single, absolute, and perfect write up or diagnosis. Why? Because it depends on how you analyze the patient's case, how keen you are regarding those salient points, or your S and your O, and your final ability to put them together and to make a diagnosis. So, how I interpret the symptoms in my point of view might not necessarily be identically the same as my classmate. And that's okay. We accept those. But please do remember when you are defending your diagnosis to stand by and be firm with your diagnosis. So that's the same thing you're going to observe when you're already going to have your CAWE or comprehensive oral written and oral exam. So oral and written examination supposed to be that's your end of the course final grand exam. So I don't know how they're going to go about it anymore now in the time of the pandemic, but nonetheless, it's something that you want to master and get tips on for the maximal yield. Okay. So it's not necessary to get the actual patient's diagnosis relative to the consultant's diagnosis. Instead, again, it depends on how you arrived at that diagnosis. So, the database we were mentioning a while ago are actually your SNO. Take note, your S doesn't only limit itself down the general data or HPI alone. You're also going to include things regarding the past personal history up until the ROS. So please remember that. In fact, your general data, sometimes we forget to include the age. Oh, moving back. Of course, the O, you know about that. It's the physical examination of your patient. Again, we'd like you in your write ups, eventually when you're in the hospital, maybe not obvious from this presentation, we'd like you to not just copy and paste everything. So take up those or nitpick among those important details that are salient and will weigh on or weigh down your diagnosis. So again, you have to summarize as much as possible, synthesize, and derive the information that's gathered. So it's not necessarily verbatim at this point. It's not all include lahat. Sana all. Oh, I just noticed our two other members are still not here, but that's okay. Please tell them we will be recording this session. That's why you received a notification earlier on. So just in case we anticipate some broken signals along the way, it'll still be available for viewing. I hope they're
Doc,
okay.
we're all present na po.
Oh, you are. Oh, sorry
Yes.
about that. Okay. So, moving on with our next slide. So, I'm going to ask some of you guys to read out the history. I hope that you have it with you. If not, you can still read out the history based on the PowerPoint slide that Bettina submitted, and I hope all of you participated in making. So, as per usual, we're going to make our session interactive. So, at any point you feel like raising a hand or asking any questions, it's okay. You can interrupt our session. All right. So for our clinical history, let's see. Kurt, are you there? Can you read out our general data, please? Go ahead.
Yes po. So this is a case of patient WER, a 5-month-old infant female. She is a Filipino Roman Catholic, and she was born on August 22, 2018 in Baguio City. She presently resides in 65A Pulok, 28 San Carlos Hills, Upper Irisan, Baguio City, Benguet. Her first admission in this institution was on February 2, 2019, and the informant is the mother with 80% reliability.
Okay, thank you very much, Kurt. So you will see, guys, that this is not a very recent case at all. So this patient was admitted in the year 2019. Patient was born in 2018. And take note, there's a difference again in our time reference. So will that be an element that you will consider in devising your diagnosis or differentials? I think so. That will definitely affect our perspective. So, is there such a place in Baguio called San Carlos Hills, or is there only San Carlos Heights? I'm not exactly sure. I think this should be heights, not hills. But anyway, that's okay. That's okay. So, not your fault, not our fault. That's all that we have provided for in our informational handout. So, that's okay. So, relevant points that you'd like to note, of course, are the elements in the general data and second, the chief complaint. Kurt, I let you read out the chief complaint as well.
So the patient's chief complaint is cough and colds.
That's right. Okay, sige. Thank you, Kurt. So right now, I would like you to enlarge your viewfinder slides or phones because right now I'm going to give you an example of how the thought process works when you're already making your POMR. So for me, the first step is actually just preparing a scrap paper or a sort of a mental note of the important or relevant salient information. So again, this is already a sort of a database where you can lift your S and O later from. So right now, thank you, Kurt. I'll do the rest of the reading for this slide. So for me, the relevant,
Thank you po.
you're welcome, Kurt. The relevant information that I derived, I'm so sorry. This is supposed to be female. So 5-month female infant resides in Baguio City. And I would add on cold season because remember your patient was admitted in February of 2019 in Baguio City. You expect the temperature to go lower, lowest actually, during February weeks, early February particularly. So let's emphasize this is the patient's first admission. And yes, I agree, cough and cold. So remember, I'm not jotting everything down verbatim. So these are the things I think are going to make sense and are going to contribute to my diagnosis later. So if you notice, there's a lot more blanks in this slide. Are you seeing my slide, by the way, guys? I hope so. Please tell me if you can't see it.
Yes po,
Yes.
Doc. Visible po.
All
Yes
right.
po.
Thank you very much. So again, if you can't read it, you can magnify it through your respective gadgets. So for the history of the present illness, I'm going to call out Gea. Gea, do you have the clinical history with you? Can you read it out? Or it's
Yes,
also
po,
okay
Doc.
if you base it here. Go ahead, please.
Okay po. So the patient was apparently well until 8 days prior to admission. She suddenly developed productive cough and colds with associated undocumented fever and irritability. There were no associated vomiting or difficulty of breathing and still has good suck and good sleep. Consult was done at a private pediatrician and medications prescribed included cefixime drops 1.2 ml twice a day for 7 days and salbutamol nebulization every 8 hours for 3 days, which offered temporary relief of the condition. 4 days prior to admission, mother observed persistence of the cough and colds, now with associated undocumented fever. Hence, consult was sought with the same pediatrician, in which ambroxol 0.5 ml every 12 hours for 5 days was given, which offered temporary relief. One day prior to admission, patient still had productive cough with colds, now with associated 2 episodes of vomiting of previously ingested milk, admixed with scanty amount of yellowish phlegm. Decreased oral intake and poor sleep. There was no fever, loose bowel movement noted. Consult was done at SLU OPD wherein they were advised admission, hence subsequently admitted.
All right. Thank you, Gaya. So, are there any questions, guys, while you were reviewing this HPI? Were there any questions that popped into your mind? Because for me, it wasn't mentioned in the clinical history, but I guess we will have to assume. But assuming is not always safe to do regarding the compliance of the mother with the medications. So I guess there's nothing here that says poor compliance. Again, it's you have to be very careful about making assumptions. So had we had a chance to ask our informant or history writer or author, then I might have asked this also. The Amxol, it was not indicated here whether it was drops or not. Again, I suppose it was drops. Take it with a grain of salt. And then take note that the patient was given cefixime. So what do we know about cefixime? Guys, is it a first generation, second, or third generation cephalosporin? Is it, let's ask Bettina.
Doc, from what I remember, cefixime is a third generation
That's right.
cephalosporin.
Very good, Bettina. So you earn 1 point today. And yes, it is actually in the Philippines the only oral form of third generation cephalosporin available in the market. So it makes you want to think, why did the pediatrician give that much of a high powered antibiotic despite seeing the patient for the first time? There is a second thing that I would like to clarify here. Remember that the patient has consulted the pedia twice, private pedia, but the last consult before the patient was admitted is at the OPD. So makes you want to think. Most people don't actually think of the OPD as a reliable consultation platform. In all honesty, most people will think of going to their private pediatricians rather than to a pediatric resident. So I just like to tickle your minds or tickle your fancy with those information. So we leave those hanging for now. Again, these are questions we might have been able to clarify or ask, but this time, sorry, but that's all we know. So could we use this information, this questionable information, as a defense later in your S and your O to defend your A? Definitely not. Cannot be. So any dubious information that is not written in your write-up or derived from the interview with your patients cannot be used as a reliable database. All right. So for me right now, going back to my mind's notes or my summary for salient information. This time, I'm going to add on that the patient had an 8-day history of productive cough and colds with associated fever that was intermittent and undocumented. In fact, there was still fever right before consultation, was associated with irritability. Initially, no effect on respiratory distress, feeding, and sleep. However, later, this changed. Immediate consult and treatment with temporary relief. Initially 8 days ago with cefixime. Now, guys, I would like you to read this out with me. Cefixime drops 1.2 ml BID with a computed dose of 6.4 mk day. So the reason why we arrived at this information, which wasn't at all in your clinical information or write up, is that in PEDIA, there are certain guidelines with regards giving or administration of medication. So we compute everything by the weight. So for instance, cefixime is meant to be given at anywhere between 6 to 8 milligrams per kilogram once a day. Now, the preparation of cefixime is 20 milligrams per ml. So make the ratio and proportion there, do the computation. Your patient is actually receiving 6.4, which means it's within the therapeutic dose. So no question as to whether your antibiotic was ineffective because it was being given at the correct dose. So as far as the medication that was prescribed is concerned. Of course, it's a totally different story when we ask about compliance. We don't have any information about that. Patient was, take note, nebulized every 8 hours. So, right here, we weren't told what the impression of the pediatrician who saw the patient first was. They're going to have a sort of kind of like an inkling as to what she was or he was thinking about. 4 days ago, symptoms were persistent, was only given on a second consult Ambroxol at 0.5 ml every 12 hours, which we know Ambroxol to be not a separate antibiotic but a mucolytic or expectorant. 1 day ago, 2 episodes of vomiting. Again, I'm making shortcuts in my head. That's why I just placed PIF, meaning previously ingested food with phlegm, yellowish. Let's specify that. With associated decreased intake and poor sleep this time, with no associated fever or diarrhea. So remember, I didn't paste the entire HPI into my list, but I only identified or nitpicked on the important points. Moving on. For the past personal and medical history, Editha, you're up next in my list. Kindly read it out. Siguro we can read out the um, from the birth history up until the immunizations.
Okay po, good afternoon.
Good
For the birth
afternoon.
history, on prenatal history, the mother was a 27 years old G3P2 2002 and became cognizant of her pregnancy at 8 weeks age of gestation due to missed menses from a previously regular menstrual cycle, confirmed by a pregnancy test done at home. Prenatal care was instituted at 10 weeks age of gestation at a private obstetrician. There was a total of 6 prenatal checkups done regularly. Ultrasound was done at 10 weeks age of gestation, revealing a live intrauterine pregnancy. There is no history of exposure to viral exanthematous diseases, smoking, alcohol, or radiation. For natal history, patient was born term via emergency low segment cesarean section due to a non-reassuring fetal status by at Baguio General Hospital and Medical Center by an gynecologist. Birth weight was 3 kilograms. Birth length was 48 centimeters. Patient had pink body with good cry and active limb movement upon birth and no congenital malformations without resuscitative measures done. Ballard's score was 37 to 38 weeks age of gestation and appropriate for gestational age.
Okay, let's go ahead. Oh, by the way, that's appropriate for gestational age. Okay, please continue.
For the neonatal history, the patient was roomed in immediately and had good suck. She was discharged after 3 hospital days, and the umbilical stump fell on the 10th day of life without signs of infection. Newborn screening was done, which revealed unremarkable findings.
So by that we mean normal newborn screening results. Okay, go ahead.
For the feeding history, the patient was breastfed or bottle fed per demand up to 5 months. Complementary milk was given at 4 months with 2:1 dilution, consuming about 2 bottles per feeding with a frequency of about 4 to 5 times.
All right. So, Edith, I will just pause you for a while over there. So, there's a little bit of a question that I would have wanted to ask with regards the feeding history. It's a little confusing, don't you agree, Edith? Because it says here patient was breastfed slash bottle fed per demand up to 5 months. So, it's kind of confusing whether the patient was started to be bottle fed at birth. But the second statement is actually going to somewhat clarify that doubt, but it's a little effy, still a little bit blurry because complementary milk was given at 4 months. So again, in my mind, did we just start at 4 months or at birth? Sorry. And second, so with pedias who are taking histories, we always ask with regards the milk formula being used what the dilution is. So for your enlightenment and further information, when we say 1:1 or 2:1, that actually refers to the number of scoops versus the number of ounces of water. So it also is stated here, it says 2 bottles per feeding, but guys, anyone who's ever taken care of an infant or a baby, adding or cousin of yours or pamangkin or neighbor, you know that there are a lot of bottles. Bottles as small as 4 ounces per bottle to as much as 12 ounces per bottle. So kind of tells us very little about whether the feeding was appropriate in terms of volume or not. In fact, at this point, I was thinking if your 2 bottles that were 12 ounces each were given, that's definitely over and above what the patient would have needed. So there's a question here whether the patient was overfed. But again, can't make any assumptions, but somewhat in my mind, I'm still asking that. All right. So moving on, Edith, please read growth and development.
For the growth and development, physical development, include birth weight of 3 kilograms, birth length of 48 centimeters, head circumference is unrecalled, chest circumference is unrecalled, and abdominal circumference is unrecalled as well.
So there's a lot of unrecalled information. And remember what we were saying also regarding the relevance of including these anthropometrics in your physical development. You have to have a present reference. So the table that should be next after this would be the present anthropometric. So you can say, patient has gained uh, 4 kilograms, which is appropriate considering the age of your patient. So again, a point that we would like to have improved in terms of the history writing of our clerk in charge. Okay, moving on. Edith?
For the growth and developmental milestones. For the gross motor, the patient had good head control. Fine motor, patient is able to reach a grasp. For the language, she is oriented to voice, and the personal and social aspects regards of hands. At present, the child is playful and active, and developmental milestones are at par with the age. For the social development, the patient sleeps at 6 p.m. and wakes up at 6 a.m. in the morning.
All right, very good. Thank you again, Edith. So, anyone who would like to make comments regarding this growth and development? Is it complete? Are you happy?
Doc, I have a question po dun sa slide
Mhm.
earlier.
Yes, yes,
Um,
go.
the one with the table with the uh, birth weight, birth length. Um, after we measure the anthropometric measurements, can we also assess for you? Can we use the weight for length chart for this
Ye-
patient?
Yes, you can. So, it's an information, Bettina, that you can include here in your growth and development as well as your actual physical examination. So, in fact, if our data was sufficient enough, one of the lines here should read growth velocity. So, centimeters per month or kilograms or grams per month of weight gain, something like that. So, yes, you are correct. We should include the present data here if that's the only point of reference we can provide, because some of our more ok mothers will keep growth charts from the first visit up until the current visit. So you'll actually see a graph. So if that's what's provided for you, then yes, that would be more appropriate. Thank you, Bettina, for your question. I hope answered your question sufficiently. Is that okay?
Yes po, Doc. Thank you po.
All right, sige. So moving on forward, we're now in the growth and development. Well, for me, the clerk who made this history said the developmental milestones are already at par with age. Mm, good enough, but I was kind of looking for more. Um, Typically, we also enumerate all of what the milestones we can see, hear, or elicit from the mother. And by mentioning this, they're kind of a little bit scanty. But nonetheless, the important thing that the assessment tells us it's okay for age. With regards to the social development, it only mentions here about sleeping time. Guys, have you ever seen an infant who sleeps 12 hours from 6 p.m. until 6 a.m. the next morning, never feeds in the middle of the night? Then you are a very lucky mom or a lucky caregiver because most infants will wake up in the middle of the night for a midnight feeding. Aside from that, they also take naps somewhere in during the daytime or the afternoon. So to say that this is a normal finding is not exactly something I would confidently put a label on. So again, something that I'd like to ask to the history taker. So I guess that's all that I noticed here. Again, the developmental, or rather the physical development, you can also state here whether or not the patient is growing at par with other cousins or neighbors of the same age. Or maybe if the child is older, remember we were saying about itemizing how many teeth there are and are they appropriate for age? Is she growing the right kind of tooth? Or did the canines appear before the incisors? Well, definitely that's also a point to be bothered about. Okay, all right. So we've tackled the growth and development this time. Last for Edith to read immunizations. Go ahead, please.
For the immunizations, the patient's immunization status is complete as per EPI, and vaccines are taken in the under 5 clinic with no apparent reactions or complications. She already had her first dose of BCG on August 23, 2018, first dose of Hepa B on August 22, 2018, pentavalent vaccine on October 12, 2018, and OPV or IPV, wait, December 19, 2018, and pneumococcal for on December 10, 2018, all taken on BGHMC with no reactions noted.
Except for the scar with the BCG.
BCG.
That's right. Okay. So, Edith, I think Bettina, when she encoded this, she already made an edit, but it says in your handouts the OPV or the IPV was actually given 191218. So I guess it was really a typographical error, right? So I'm going to throw the question right back to you, Edith. Do you personally think that this is a complete vaccination status for someone who is already, how old is your patient? 5 months.
Hello, Doc.
Yes, Edith.
I think by the age of 5 months, supposedly there should have been a second dose of DPT for the patient and IPV as well, if I'm not
Mm.
mistaken po.
That's right. So, very correct, Edith. So, it's not really complete as per EPI to our clinical output. So, you're right. In fact, might have even already had a third dose, so second or third dose. Because remember, some children will have, some infants rather, will have their vaccines as early as 6 weeks of life, and then in monthly intervals after that. So, in 5 months, you should have already completed or nearly completed it. So, guys, let's make the correction here. The immunization status is not complete at all. Okay? So, again, take the information with treat it with extra care and take time to read it, because apparently some misinformation can still be given to you despite this being an actual history of a clerk that we have in the hospital. Again, thank you for your comments, Edith, and thank you also for your answer and reading out. Okay, so we're now moving on to the past medical history. Nedima, can you help us out? Please read this for us.
Hello, Doc. Good afternoon.
Hello. Go ahead.
Past medical history shows that there was no history of hospitalization. The patient does not have known allergies to food and drugs, and there's no history of trauma or accident.
That's right. So, Nedima, is there anything you would have asked me if I were the history taker for this patient? Anything you'd like to ask? Any other additional information?
Is it possible to ask at this point about the okay that should be about the parents or because no allergies to food and drugs. What exactly has the baby been exposed to? And for them to say there's no allergy to food and drug, is it just the milk or have they tried other um, food sources to know if, yes,
Yes.
basically,
Good catch on that. So, if you'll notice in our feeding history, there was no mention of food introduction just yet. So, as early as 4 months, some parents have already started feeding with semi solid foods, at least for taste. So, it's really a little bit of a conflict here, whether or not the information that's being given to us is appropriate, or maybe the historian missed out on some information in the feeding history. So, a good point there. So, good, Nadima. The other thing probably that I would like to ask with regards past medical is not only hospitalizations. Remember that the patient can still be sick and consult at an outpatient facility or private doctor's clinic. Not really a hospitalization, but that can still be relevant. What if this patient has been seen in the OPD for once every month in the last 5 months for recurrent respiratory infections? We don't really know because the information is lacking in that element. So again, yes, good catch on that. Neddy, we'll go on to the next part. Go ahead, please.
for the family history, both parents are apparently well. There, there's a family history of diabetes mellitus, hypertension, and breast cancer on the maternal side. There's also a history of bronchial asthma on the paternal side. No history of disease like heart disease, arthritis, and stroke on both sides.
All right. Thank you again, Neddy. So, again, for me, rather than asking so many family histories of illnesses that are not relevant to our actual patient situation, maybe the thing that I would have asked here is a history of maybe allergic rhinitis, or maybe, yes, the other food allergies that we mentioned. What else? Maybe you're familiar with the so called allergic march or atopic march. So that means that bronchial asthma actually has precursor illnesses, including allergy in the skin, allergy of the nose, or allergy to food and drugs. So maybe those are the relevant ones we could have asked. Because if you are going later to your diagnosis, maybe some of you were thinking, oh, could this be an allergic disorder? Could this be a bronchial asthma? If our family history was comprehensive enough to mention those, then those could have been supporting elements in our defense. All right, so moving on. Neddy, please go ahead.
For the socio-environmental history, the patient's father is a 29-year-old currently working as PNP police officer. The mother is 27-year-old and currently unemployed. The primary caregiver is the mother. The patient is the third out of four siblings. There are four family members noted with the same symptoms. The patient lives in a congested neighborhood in a two-story house with 5 rooms and 8 occupants. The source of water for domestic purpose is from the local water district, while the drinking water comes from water refilling station. They have no pets. Garbage is usually segregated and collected every Wednesday. Toilet is flush type. Hand washing is practiced before eating, after using the toilet, and before preparation of food.
Thank you again for that, Neddy. So again, it is a mention of preparation of food of the patient, possibly of the parents. We really don't know. Neddy, my question to you is this. With regards to your social and environmental history, we know that there's a checklist of things we should be asking our patient. But if you were thinking of a social or environmental origin of the respiratory infection of your patient, what would you have asked?
Maybe if they're exposed to any pollutants around, is there someone who smokes? Do they stay in a place where they're exposed to fumes, or what kind of? How do they cook? Do they use the? Do they cook with things that generates fumes or something like that?
That's right. Very good, Neddy. So definitely those elements are important to identify the etiology of the respiratory infection of your patient. So it might be helpful. It's not the end all and be all, of course, of figuring out the etiology of your patient's illness, but it would have had a heavy bearing on our database. Okay, thank you so much again, Neddy. I will read the rest of the slides for the review of systems. For the general survey, there was no weight loss. There was history of febrile episodes, a decreased oral intake, and irritability. With the skin, there were no rashes, no pallor, no jaundice, no cyanosis, no sores. In the head and neck, no trauma or headache. So I started smiling at this point. How can you figure out if your 5-month-old patient has a headache or not? Right? So that should have been there. With the eyes, decreased tears. So that's definitely a red flag sign when it comes to your diagnosis of dehydration. No redness, no discharges, no blurring of vision. Smile again. So blurring of vision is very difficult to assess for a 5-month-old. In fact, even children, it's really hard to tell. So shouldn't have been there. Same is true with the complaint of tinnitus in the ears. Well, the absence of pain, no discharges, no sneezing, at least that's okay. It looks feasible enough to ask and do. With the nose, no colds. So take note, your patient is complaining of colds, but in your review of systems, it says no colds. So it makes me want to think again, who made the mistake here? The first part or the second part? We can't tell. Again, no point of clarification. There was no nose bleeding, no congestion, no ulcers, no gum bleeding in the mouth and the throat. Respiratory system, positive for cough, no dyspnea, no shortness of breath, no palpitations. Another element of the ROS you can never ask your 5-month-old about. Same is true with easy fatigability, but that can be indirectly manifested as they may be getting tired too often and too soon while feeding. That's okay. So, with GIT, vomiting, positive, no diarrhea, constipation, no hematochezia, no melena. So again, it's in GIT where we found the vomiting, but take note that there is such a thing as a post-tussive vomiting that can still be included as a respiratory complaint. I would say I'll include it into both systems, just to be sure. Musculoskeletal, no weakness, no trauma, no swelling. The weakness element, you can actually have included that already in your general survey. Maybe what was being referred to here is muscle weakness. So if you notice, there's also no neurologic or psychiatric system mentioned. So take note here. Oh, please ignore the second column for now in the part of, oh sorry, yeah, this is the correct slide, sorry guys. So now our notes have already been populated significantly. The other half is now filled, and now we're including not verbatim elements but summaries. So guys, I would like to you to focus your attention on the second column, which is now saying that there's an unremarkable prenatal, but I'd still like to include that information on being born CS. Why? The part where the vaginal squeeze occurs, as well as the exposure to natural flora in the vaginal canal, is actually going to load up your probiotic stock. So generally, what they say is that CS-born babies have less probiotics in their system, are usually more prone to respiratory infection. So I think in the back of my mind, I'm thinking, oh, I think this is relevant information. I'd like to include it. So there was no mention that, or rather, there was a mention that there were no congenital malformations and that the newborn screening was normal. So I'd like us to have this information on hand because later if I decide to give antibiotics, there are certain restrictions for, like, for instance, G6PD patients who are going to be given sulfa antibiotics. So definitely that's something you need to include. Next, introduction of formula 1 month prior. So again, that's how I understood the history. With an appropriate dilution, yes, but two bottles per feeding 4 to 5 times a day. With a normal growth and development, with incomplete vaccinations for age, with no previous hospitalizations, with a family history on the paternal side of bronchial asthma, no family members who are currently sick, but they live in a congested neighborhood, quote unquote. But if you have 8 occupants and 5 rooms, that's relatively livable, I would say. But if we were to base it on first world countries whose rooms are entirely large, now if the room is just a few square meters in area, and then that would be an element for congestion, really. I wonder if you guys have come across congestion index in your lectures in community and family medicine. Back in my day, I didn't. We didn't have that. But that's something very important to include as an information and a computation that can be derived based on your social and environmental history. So I would say let's just take it from the author, congested neighborhood. In the ROS, I'm including very few of those systems and symptoms felt, including the fever, the poor oral intake, the disturbed sleep without weakness, no pallor with decreased tears, no colds or congestion. There was cough but no dyspnea, vomiting but no diarrhea, and there was no decreased urine output. So from the foregoing, guys, you are now beginning to see that you are narrowing down the information that you have derived from your database into those salient points. So again, these are very important because you will use this as a basis for your SNO in your defense of your A. So, Bettina, may I please ask you to read out our physical examination, the whole thing na.
Okay, Doc. For the general survey, the patient is awake, very irritable, arm-borne. I'm not sure if that's a typo. I'm not really familiar with the term arm-borne, Doc. And is in cardiopulmonary distress. For the vital signs, the cardiac rate is 145 beats per minute. The respiratory rate is 62 cycles per minute. The temperature is 37.8 degrees Celsius. And the oxygen saturation is 91% at room air. The anthropometric measurement of the patient weighs 7.5 kilograms and has a length of 65 centimeters.
So before going on any further, I know you can critique this part already, Bettina. There are certain elements again that are missing. Can you pinpoint which one they are?
Doc, for the anthropometric measurements, although it was told by the mother that different circumferences were unrecalled, the examiner should have elicited measuring those circumferences for the anthropometric measurements.
That's right. So the anthropometrics that the mommy couldn't recall were the birth anthropometrics. So the clerk or the student in charge should not forget to take the actual figures now. So it's really sad because we don't really have a reference at all in regards that. So as to your earlier question, Bettina, regarding arm-born, so that's actually a medical term. So that's how we describe babies who are being carried in their arms by their moms when they come into the ER. So, if this were a mobile child or an ambulatory child, and you say, oh, patient was arm borne, or patient was stretcher borne, or patient was wheelchair borne, so patient was probably not able to walk because he was very, very weak or very sick at the moment. So it gives you an idea of how the general condition of your patient is in terms of mobility and comfort and maybe activities of daily living. So yes, we do accept this. It's an actual medical term. And I would also like to maybe add on a little bit of something with regards to your stating of your vital signs. Oh, incidentally, guys, you take a look at the vital signs. There's already the oxygen saturation here. So it's definitely something that you must not miss reporting in cases of pneumonia and other respiratory infections. So my tip for you for the rest of the vital signs is also tabulate the normal so that you can say for sure that, oh, the range of cardiac rates according to my código. Oh, by the way, guys, I don't know if you can see, but this is an accordion type folding reference. So it's called Pedia Shades. So this is actually a pocket reference that we can put in your pocket and use as a quick tool in case you can't remember some of the things that are being asked in the rounds or some very basic information in computation. So, in fact, the first portion here says the tabulation for normal heart rate, blood pressure, and respiratory rate. So it's very important, really. So I would say cardiac rate 145 beats per minute, open close parenthesis, normal range for 3 to 6 months is 90 to 120. So definitely your patient is tachycardic. RR of 62 cycles per minute is supposed to be anywhere from 30 to 45. So if I make a note like that, so right beside that, those vital signs, I can already say, yeah, patient is really in cardiopulmonary distress. In fact, I can also gauge whether this is a mild, a moderate, or severe respiratory distress. So it's a good idea to get your pocket references, especially when you're in the hospital already. It's very, very useful. Very, very nice. All right. What else? Include your assessment. So for me, I would include the assessment for my weight and my length. And from there, actually, I can derive my body mass index. This clerk forgot to do it again, unfortunately. Okay. All right. So let's move on. Let's read out the rest. Uh, who did I ask to read? Yes,
Me
Medina,
pa,
go
Doc.
ahead.
Me pa. Um, for the examination of the skin, there is no noted cyanosis, pallor, or jaundice. The patient's skin is warm to touch with fair skin turgor. For the head and neck, there are no gross deformities with flat anterior fontanelle, slightly sunken eyeballs, anicteric sclera, pinkish palpebral conjunctiva with no nasooral discharge, non-congested turbinates, midline septum, occasional alar flaring, dry lips and buccal mucosa, no circumoral cyanosis, no neck vein engorgement, and has cervical lymphadenopathy at the right submandibular area.
So I would say this is a very, very information-packed section of your physical examination. You're going to have to take note of all of this in your notes later. Go ahead for the next.
There is symmetrical chest wall expansion with subcostal and intercostal retractions, resonant inspiratory wheezes, and bibasal reels. The PMI is noted at the fourth intercostal space, left midclavicular line. There are no heaves, no thrills. However, the patient is tachycardic with regular rhythm but no murmurs. The abdomen is globular, non-distended, with normal active bowel sounds, tympanitic, soft, and no organomegaly. There are no gross deformities in the extremities, also no noted edema, pinkish nail beds, full and equal peripheral pulses, and a capillary refill time at less than 2 seconds.
Do you consider that normal, Bettina? The less than 2 seconds? Is that okay?
Yes po, Doc.
That's right. So that's considered normal. So capillary refill time is A-okay. What else? Anything we'd like to comment on this? I don't think I have any. And again, there's no neurological exam. So this time, thank you again, Bettina. I'll read out the rest of the salient information that I've made up in my head. So now I'm taking note of the general characteristics from our patient being very irritable and in cardiopulmonary distress. And this time, I may or may not put the actual values, but right now I'm making assessments already whether it's normal or not. So I go ahead and say patient was tachycardic, tachypnic, and hypoxic. And this time, I'm also gauging the anthropometrics. So +1 standard deviation weight for age, 0 standard deviations weight for height, 0 standard deviation length for age, and 0 SD BMI for age. So in short, we're saying everything appears to be normal as far as the weight and length and BMI are concerned. Now, there was no cyanosis or pallor, but there was fair skin turgor. There was no nasooral discharge, but occasional Eller flaring was noted with, take note, dry lips and buccal mucosa with no circumoral cyanosis with a cervical lymphadenopathy on the right submandibular. It's kind of strange, really. Your patient only has a right-sided one. So in terms of systemic symptoms, you may want to rethink, is this something that's brought on by a local inflammatory process that's why it's located in the right? Were you thinking that? Maybe we will see. So for the chest and lungs, I'm going to include practically everything, but emphasis on the symmetrical chest wall expansion with the retractions located subcostally and intercostally, with inspiratory wheezes and bibasal rales. So rales are considered coarse crackles. So very noisy. You will never mistake it for anything else. You will hear it right away, right at the time that you put your stethoscope on the patient's chest. So it's sort of very distressing. It makes you want to think, I think I have a diagnosis already when I hear those sounds. Full and equal peripheral pulses. So it tells us something about the circulation despite the blood pressure not being mentioned in our output. Capillary refill time of less than 2 seconds. So now our jotting down of information is complete. We are now on our way to make our problem-oriented medical record. So this is probably the part that you guys didn't receive any lecture on, but I am glad because you were able to identify your problems quite comprehensively, if I may say so. As a tip for your future exercises on the POMR, the one that's going to be graded, your POMR or itemization of the problem should follow the following guidelines. So, the problem that we identify should be short and concise. So we're not going to say cough of 10 days in duration, productive post-tussive vomiting with pertussoid sound. So it's okay for me if you just say productive cough, at least in our patient. It's usually the chief complaint or complaints, but there is certainly some more elements that you would like to add, especially if these are going to add on to the uniqueness or the pathognomonicness or the gold standardness of a certain symptom in the diagnosis of a definitive illness. So there's no words like that, but I'm just saying it's how I feel that you will understand it better. So take note, if my problem number one was purely just a complaint of cough, which was the chief complaint of the patient, for instance, what if I made my problem number one as cough, fever, and wheezing? Now you're narrowing down your differential diagnosis from the initial impression of just the cough to 100 differential diagnosis to just maybe around 15 differentials if you just have cough, fever, and wheezing. Additions of other details are going to narrow down your diagnosis. So make sure that you take these jotting down of the problem with care as well. So the tips for you are: one, try to create a single diagnosis from the combination of the signs and symptoms. And of course, you can tabulate a second problem if you feel that they're completely unrelated with the first one. And you have to review and reread your paper for hidden problems. You'll see later. So, another tip, maybe there's a symptom or a sign or a laboratory finding pointing out to a group of diseases. Like, for instance, in your cases with diarrhea, maybe you can say in your problem diarrhea, abdominal pain, and fever, not just diarrhea. Whereas maybe you can combine also your symptom signs and lab findings. Lab findings, doc, can I include them? Well, yes, if they were part of your history of the present illness or past medical history, then yes, you can. So, for instance, if my patient had an x ray and there were infiltrates, and likewise, there was a time that our patient had retractions, wheeze, stridor, crackles, and infiltrates. Wouldn't that be more specific, leading towards a diagnosis? Or something that's pathognomonic. For instance, I'd like to mention the Bitot spots in vitaminosis A, or findings of blast cells in the peripheral blood smear or bone marrow aspirate in leukemia. So if you have these as problems, put them right on top. So they're the most important ones. They're the most leading towards a diagnosis. So again, I'm looking at your problem list right now. Like I said, it's comprehensively done. Thank you. Kudos to that. Everything is here. So the cough and colds, the fever and the irritability, the vomiting, the decreased oral intake, the poor sleep, the decreased tears, the nasal flaring, the intercostal retractions, the bibasal rales, and the tachycardia. So yes, you have 10 problems, but couldn't you just bundle them all up into a single problem? Don't you think? Well, that's the way we do our POMR. So if I were to write up a POMR of my own right now, but again, I'm telling you guys, as a disclaimer, my problem list may not be necessarily the same as yours. So if you decided to itemize each one, it's going to be really difficult because you're going to form an assessment for each and every problem. So what I did, guys, couple up the productive cough, colds, fever, respiratory infections, irritation, crackles, and wheezes. So take note that I'm putting my submandibular lymphadenopathies as a second problem because I'm not exactly sure how that would relate to your first problem. I couldn't explain it really. The third, take note of the non-medical problems in your problem list. So this includes number 3, which is a non-up-to-date immunization. I would think that the bottling is also a problem because the patient should have been on breastfeeding at this point. And there was a question with regards overfeeding. Again, something of a personal note. Number 5, the fifth problem with regards to congested neighborhood. Again, to me, it's okay, but to you, it might not be. Maybe your number 5 is financial difficulty. Patient has been going for vaccinations at the OPD of the Baguio General Hospital and sought consult again at the OPD a second time. If you feel that that's where your thoughts are bringing you into, then yes, you can add that as a problem number 5 or problem number 6. So take note from the table that you have created as a group. There's a couple of tables that I would like to add, namely this date of onset, date recorded, date resolved, or the status. So for this patient, all of the problems are currently active. Pero like for instance, you might have a history of a surgery for, say, for instance, just an example. Patient has had a neurologic operation and a shunt was implanted. So maybe you can put as problem number 6, status post, VP shunt, implantation, um, January 1 of 2019, inactive. That's still part of the problem. Remember, even if your patient has a shunt before, but your patient has fever now, one of the considerations for these patients are recurrent infections. So maybe that element of whether or not this particular problem is worth putting in your problem list again becomes very subjective at this point and depends on how far you're thinking in terms of your thought process with regards to your diagnosis. So for me, this would have been the most appropriate. So it will make your job much, much easier because the primary problem is just problem number 1. Okay? So to make things easier for you, because like I said, for each problem, you have to identify your SOAP. So Let's just stick for the purpose of this discussion today to problem number one, which is cough, colds, fever, distress, dehydration, and oscillatory findings. All right? Yes? Okay. All right. So maybe you're saying, oh, how do I tell? How can I know if this one is just a single problem or two problems? It depends on you. In fact, there's no hard and fast rule with regards how many problems you should assign to your patient. It depends on your approach. Okay? All right. So, as a review, your assessment after you've formulated the database in your head, after you've already identified also your problem list, this time we're going to use your SOAP. So problem number, then SOAP. So the S and the O, we've already done that. We've already created our database. So all you have to do is pull out the first column, which are all the subjective ones, and the second column, which are all your O's or objective ones. But remember, we're tackling problem number one at the moment. So there are some elements of your database that we earlier created that might belong to a different problem or they might be a replication. For instance, this information belongs to problem number one, but also belongs to problem number two, something like that. Okay, so as a recall, when we formulate our assessment, you have to have a primary diagnosis as well as your differentials. So that's part of our rubric. But if I may add, in your primary diagnosis, you need to mention also your classification, etiology, clinical status, and complications. So again, as a disclaimer, there are certain consultants who will just stick to the primary diagnosis and that's okay. But for the purpose of academic exercise right now and to hone your skills with diagnosis, let's go and do the best of the entire gamut of the spectrum of a complete diagnosis. Now, part of your discussion is supposed to be a basis or defense. So this is what we've done in a typical CPC. So I believe my patient is like this, and all of his symptoms can be explained by the following processes, according to the following references. These cases present with the following, so on and so forth. So again, it's your brain trying to dissect the diagnosis and to try and check if it's actually appropriate for your patient. The P, as a prelude to our later slides, diagnostics, therapeutics, and the therapeutics actually consist of your main, supportive, and that's supposed to be under that patient education. So, your diagnosis as a group, which I assume you have already discussed together, is that correct? Yes? Everyone agrees? This is your diagnosis? Or
Yes
are
po,
there
Doc.
still violent reactions? People who are still saying, oh no, that's not my diagnosis. That's my classmate's diagnosis. I believe it's otherwise. Did any of you think of that? Possibly. So that's why there's a ranking. It became your differential diagnosis already. So let me just read out your diagnosis. It says community acquired bacterial pneumonia to consider streptococcus pneumoniae infection. Hmm. Very nice, very nice. So right now I'm looking at your diagnosis. There's the main diagnosis, there's an etiology. So at least elements of your diagnosis are present there. But for me, this is how I would have written my diagnosis. My number one, indicative of problem number one, and then A, colon, pediatric community acquired pneumonia. So, if you recognize in pediatrics, we always say PCAP. It's not CAP. CAP is adults. So, when we say PCAP, it's pediatric. So, that's anywhere from not neonatal. So, up until maybe our cutoff is around 2 or 3 months. So, maybe from 3 months and onwards, you can already call it a PCAP. So, I'm also including a C. I know you guys have already been given modules by Dr. Doc regarding your respiratory lectures. I hope she has mentioned to you the classification of pneumonia, risk stratification. So we always use this in the hospital. So it's either pick up A, B, C, D. Those that are admitted are the C's and the D's. So for me, I would mention with a bacterial etiology, probably atypical, in moderate respiratory distress, and if I may add, in moderate dehydration. So I'm going to sort of include here my other diagnosis or differentials already. But technically, it's just the main diagnosis that this has an important bearing here. In the same time, I'm trying to rule out a bronchiolitis versus bronchial asthma or a probable wheezing related respiratory infection. So, did I check up the main, did I write down the diagnosis? Yes. Did I classify it? Yes. Did I state the etiology? Yes. The clinical status? Yes. And the complications? Yes. Everything is complete. So, technically, this would have been the most ideal. But again, my diagnosis is not necessarily the same as yours. So, what if you say, probably bacterial etiology? Possibly streptococcus. That's okay. And then in my differentials, rule out versus atypical etiology. That's okay too. So remember, it's how you defend your diagnosis that will be the basis for your grading. How well you defend your diagnosis is also very important. But our starting point definitely is an appropriate, correct, and good assessment. Okay. So, um, who would like to explain how you came up with a diagnosis of CAP? So I'm seeing a tabulation here. So with the next, Bettina, did you assign time to discuss this to us? Or,
I have assigned reporters for the POMR product
oh, you
register.
did?
Yes po.
Sorry. Looks like I preempted every single person's presentation in that case. Okay, who is tasked to discuss to us the assessment?
That's me,
Oh,
Doc.
okay. Neddy, go ahead. So, why do you think your patient has CAP, probably strep?
Okay. Before I start, I just want to say that all the comparison with the patient's data came from our textbook, the Nelson's textbook of pediatrics. Okay, so the first important data there was the tachycardia and the tachypnea because the textbook says that tachypnea is the most consistent clinical manifestation of pneumonia in an infant, and they usually commonly present with tachycardia, but tachypnea is always there. Then the inspiratory wheezy and bibasal rails would tell that there's fluids in the lungs. So if you think of that, you would, in pneumonia, it's classic that there's pus accumulation in the lungs. And our textbooks also says that auscultation of the chest would reveal crackles and wheezing. Then the subcostal and intercostal retractions, the lung is resonant, and there's occasional alar flaring. So this is just telling us that the patient is in respiratory distress. She's trying to take in more air. So her lungs are filled up with pus, and then she's trying as much as possible to like gasp for air to take it in. So that's why she's having the retractions, because her chest muscles, her muscles are basically like there's increased work of breathing for her. So the textbook says there's increased work of breathing accompanied by intercostal, subcostal, and substernal retractions, nasal flaring, and the use of accessory muscles is common. Next slide, please. Doc?
Yes. Would you like me to take you to the next slide?
Yes, please.
How about this one?
No, the one before.
This one? Or this one?
The,
Oh, this
the
one.
next one. General survey.
Okay.
The general survey.
Okay, here we go. Go ahead.
Yeah, this is just supporting the diagnosis because she's irritable, she's febrile, and then she has decreased oral intake. So the textbook says that usually they have a prodrome of upper respiratory tract infection, which follows through because 8 days prior to admission, they had she was just having productive cough and all that, and then we saw that the symptoms progressed. So usually in infants, there's a prodrome of upper respiratory tract infection with diminished appetite that leads to this usually leads to abrupt onset of fever. They are restless, apprehensive, and they have respiratory distress. Then she has decreased tears, dry lips, and buccal mucosa. I attributed this to the dehydration from the vomiting and the diarrhea she's been having. Then the cervical lymphadenopathy at the right submandibular area. Cervical lymphadenopathy is a common finding in lower respiratory tract infection. Next slide, please.
Before going to the next slide, Neddy. So remember that I mentioned a while ago, it's unilateral, right-sided, submandibular area lymphadenopathy. So in your references, does this particularly strike you as something unusual, or does the reference tell us it can be unilateral, it can be bilateral? What were you able to read on?
Yes, yes. This actually, I had to do a lot of research on this part because, why is it just unilateral? Is it just one lungs? Well, we're hearing about basal crackles and all that. So, from the physical examination, there's signs of affectations of both lungs, but the cervical lymphadenopathy is just on the right submandibular area.
That's
So,
correct. So even in your physical examination, there's nothing suggestive of a unilateral infection. Like for instance,
yeah.
a selective percussion finding of increased tactile or vocal fremitus, or or decreased uh, tympanitic sound or resonant sound on one part of the lungs. So it's not unusual. So you're going in the right direction, Neddy. So did your group. So it's correct. So by all means, you were defending the pneumonia as a textbook definition and comparing whether or not your patient's symptoms can be accounted for by that description. So we'll see the rest of your slides. So the next slide goes with this one.
Okay, yeah, this is the prodrome. 8 days prior to admission, she developed productive cough, cold, which associated undocumented fever and irritability. There were no associated vomiting or difficulty of breathing, and she still had good suck and good sleep. This is the prodrome I spoke about earlier. That pneumonia is frequently preceded by several days of symptoms of an upper respiratory tract infection, typically rhinitis and cough. So at this point in time, the infection is still progressing. Then cough with colds associated with 2 episodes of vomiting. There was no fever, loose bowel movement noted. This is the prodrome period. So usually some infants with bacterial pneumonia, they might have associated GI disturbances such as vomiting, anorexia, diarrhea, abdominal distension, secondary to paralytic ileus. Then the age of the baby, the 5 months old, was what made us consider the streptococcus pneumoniae because it's common for children between 3 weeks to 4 years of age. The most common cause of pneumonia for them is this pathogen, streptococcus pneumoniae. So with that, we put all that together and it strongly suggested pediatric community acquired pneumonia secondary to streptococcus pneumonia infection.
All right.
That's
I would say that's a very good defense. So, like I said, you encountered your case and then you made a defense, and basically, most of the symptoms have been accounted for. So, that's what we do in our CPC, or clinical pathologic correlation. So, yes, that's right. It's strep pneumoniae. However, take note, Neddy, I don't think you mentioned here that your patient was using already antibiotics. So your patient would have responded to cefixime, which has coverage for strep. So maybe in your mind right now, would I have added something else to my diagnosis? Is it better if I added a second etiology? Or is this a case of a resistant infection? Would I have mentioned strep pneumoniae that has resistance?
resistance.
Hmm.
Yes, Yes, I think I would rather lean towards strep pneumonia that has resistant strep pneumonia. So maybe she should have been treated with other
Other
vanco,
antibiotics. Ooh,
vancomycin.
vancomycin. Oh, that's for MRSA.
Yeah.
MRSA is really a very invasive kind of etiology of pneumonia. It's something that's also very deadly, but not quite. Not there yet. At least in our impression of this case. At least not for me. So I'll explain that a little bit more later. So thank you again, Nikki, for that. So I'm going to go ahead and show you the rest of my, again, this is my diagnosis earlier. So I'm just posting it here for recollection. So right now, I'm thinking still bacterial, but I didn't label the exact type of bacteria. In fact, I was leaning towards atypical. So now, the defense, again, just like Neddy did a while ago, was to defend her diagnosis because she believes her patient has the following because. So you were on the right track, as I mentioned earlier. But this time, remember that we're defending our diagnosis piecemeal style. So I would say I would defend my diagnosis in this way, slightly different from how you defended yours, but not to say that it is incorrect. In fact, it's okay. It's okay as it is. But for me, this is what I would have wanted to do because I wanted to explain each of the elements of the diagnosis in detail. So I go ahead and say it's community acquired because patient has never been admitted or is currently confined to a hospital facility. And I would also say that the cold season and the effect of that to the community with the RTIs being more common, especially when we're in close proximity, living together, huddled with each other, the spread of bacterial, well, at least bacterial and viral infections can be included. And the patient does actually live in in a community with a high congestion index. So remember, our time frame is February. The flu season is already there, and low temperatures. Again, during that time last year, we went as low as 8 to 9 degrees centigrade. So there is high microbial air drop load in the air, slower clearance of viruses and bacteria, is most likely the source. It's community acquired. I think it's bacterial because it has a longer and progressive course. So I'm kind of putting it side by side with a viral infection. So viral infections are usually self-resolving. Usually, though patients with bacterial infections have longer duration, aside from that, also have fever, which our patient did have, and later manifested with signs of respiratory distress and use of accessory muscles. I'd like to say atypical because, for one, you actually treated your patient with an antibiotic that has good coverage for both gram negative and gram negative, gram positive and gram negative bacteria, has
Mhm.
definite coverage for strep pneumoniae, but why did the patient not respond? So maybe we're considering atypical organisms. I'd like to say your patient is also classified as Class C based on the PAP 2016 risk classification for PCAP. So as an additional support to that, similar to what Neddy just presented, again, anywhere from 4 months to 5 years, we can have both viral as well as bacterial etiologies. But take note here that still the 1 to 3 months can have a chance for the atypicals in the 5 years or older. So actually by presenting this slide, my diagnosis just got less effective or less convincing. So, incidentally, the pickup classification is here. Again, you can magnify your slides by using your zoom function. So here, that pickup is actually divided into either a minimal, low risk, moderate risk, and high risk pneumonias. So our patient does fall according to the moderate risk or PCAP C. So I'm going to leave that for you guys to read. I would say your patient is of respiratory distress moderate type because not only is the patient manifesting with tachypnea, use of respiratory muscles, patient already has hypoxemia. Now, if your patient manifested with cyanosis already, that would have made for a severe type of respiratory distress. So this is a misclassification, a clinical one at that, that you might come across during your rotations in the hospital. So the other manifestations for respiratory distress are also mentioned. I believe the patient also has moderate dehydration because of the following, again, falling into this category. And right now, I'm going to defend my diagnosis, but this is not the right slide. So you can defend it in a manner that's like almost like textbook. But for me, I made it somewhat easier and diagrammatic for you. So I guess I can put all of my symptoms and how they led up to the illness by means of a diagrammatic figure. So, come read this with me, guys. The environmental triggers, especially the cold weather, flu season, February, might have triggered the environmental infectious causes, including but not limited to strep, Hib, viruses, and mycoplasma, to enter our patient's airways, specifically since they are not so mature yet and they are narrower. That's a predisposing factor for them to get sick and more frequently, more severe in um, level. This will lead to inflammation of the airways and production of infiltrates and also acute phase reactants, production of lymphocytes, activation of macrophages, and so on and so forth, producing a lot of respiratory debris, leading to the formation of the bipassal rales or crackles, and the narrowing of the airways, it's not written here, but can lead to a hyperreactive airway, here, thereby resulting to the wheezes. And that respiratory compromise is going to cause your patient to have tachypnea as well as hypoxemia and manifest with air hunger and perfusion deficits. Patient will hence become irritable and fuzzy with a disturbed sleep, and that in itself will lead to water loss and dehydration and weakness. The expectoration via mucus cannot be expectorated via spit, especially in a person or a patient who is as young as an infant. So it comes out into the vomitus and later on spreads again into the community. Come the background of incomplete vaccinations that will also predispose our patient. So what difference is there between the summary that Neddy read, you prepared as a group, versus mine? So there are two different presentations, but they basically accomplish the same thing. We both defended our diagnosis. So, okay? So you get the flow here, guys. So there's the easy way, there's the toxic way, there's the paragraph way, there's the tabular way, and also the figurative way, which is also over here. Did I explain everything in my problem number one? I guess so. Yes, pretty much. But again, I like how Neddy was defending the diagnosis in terms of the main etiology of the strep. So I guess right now, I think it's still strep. Strep mixed, that's still possible. So maybe I would say strep with a typical. All right. So we're moving on. Whose part is it to report the differential diagnosis? Is it still you, Neddy?
Yes, yes. Yeah.
Oh, here. Okay, you have a lot of assignments today. Would you like to take a break? Okay, all right. You can go ahead.
So for our differential diagnosis, we're considering pneumonia, the community-acquired pneumonia, bronchiolitis, and croup. Um, Usually, they have almost the same clinical symptoms. For tachycardia and tachypnea, it's common in all three, apart from croup, where it could be variable, so it's not always consistent. For the inspiratory wheezes and bibasal rales, it will always be in all three. Then the subcostal and intercostal retractions, it will always be in all three. Doc, next. Then the irritable and history of febrile episodes, it's consistent in all three. While dehydration it's common, it's a classic finding in community acquired, is not really consistent with croup. But for bronchiolitis, it depends on the severity. So it's variable with bronchiolitis, it's not consistent. Then for lymphadenopathy, it's a common finding in all three. Next doc, please. Okay, then the prodrome of 8 days prior, there was onset of productive cough, colds, stead fever, and irritability. It's common in all three. Productive cough, and then the fact that this can happen to a 5 month infant is common in all three. So that's basically why this were most common. These were our major differential diagnosis. That's all.
All right. I think that's well formulated. I would say that would have been my considerations as well, but I think croup is a minor consideration. There is a synonym for croup, Neddy. It's called, what is its mm,
Infective bronchiolitis.
what is its more common name?
Bronchiolitis, the
Croup.
whooping cough. I can't
Whooping
remember.
cough.
I just studied that
Uh,
bronchiolitis.
uh, okay, while you think of that, let me just answer a phone call.
um,
Okay, let's just take a 5 minute break for a while.
Laryngotracheobronchitis.
Kurt, may kausap saglit si Doc.
Ah,
5 minute break muna daw.
ah, ah,
Hello, everyone. Thank you for waiting. So that was a short break. So we were at the differential diagnosis. So I was asking, Neddy, have you researched? There's a synonym, a more common term for crew or crew. Hello, anybody home?
Doc Kurt answered earlier po.
Oh yes, I'm so sorry.
I
I
think
didn't hear.
it's okay po.
What was the answer?
He answered
Acute
laryngotracheal
laryngitis.
bronchitis po yata. Yes.
Laryngotracheobronchitis. Okay, got it. Correct. So, if you actually encounter patients with the CRU or the acute laryngotracheobronchitis, they have very, very unique kind of cough to them. So, we call them a seal-like cough or a barking cough. Literally, guys, if you've ever been to SeaWorld or if you haven't, check out the video clip of a seal. How they bark like a horse na mamalat in Tagalog na dog. That's how the sound of the cough would be like. So, CRU as a diagnosis is basically a giveaway. So, there was nothing that was mentioned about the cough, but then again, we can only assume that our reporter or history taker was succinct and descriptive enough in his writing of the HPI. So, incidentally, CRU is usually viral. So right now, we're intercrossing between, okay, I'm considering maybe a viral infection, and then it became pneumonia that's bacterial, or maybe you're thinking, oh, the reason why your patient didn't respond to the cefixime because it was because it was a viral infection. That could have been the reason. So all of those, the thoughts that are going on in your mind should have been included as well in your defense. So that's the beauty of actually writing your defense in a prose or tabulated or bulleted type rather than the typical tabulated plus or minus type. So you can, there's no limit as to how much more you can talk about with regards a written versus tabulated one. Okay, so you were right, Neddy and Group 10A, for saying that in bronchiolitis, one of the very unique characteristics is that they have a wheeze. Now, I will correct your earlier statement, Neddy. Not all pneumonias in children actually wheeze. So to say that, I think you had a slide over here. Inspiratory routes and bibasal routes across the board positive for all pneumonia. It's not actually the case. But if it's a pneumonia in an infant, that's still possible. So remember how I defended my answer. It's a pneumonia that has a wheezing because of the anatomic predisposition. And second, because atypicals, specifically mycoplasma or chlamydia, are actually infections that do cause wheezing. So that's an established fact. So I would say, yes, you're on the right track, but needs a little bit more polishing. Okay, so again, kudos to you, to your group, and I think that was very well done and very well said. So right now we're moving on to our, well, this is a sample of how I defended my bronchitis. That's okay. And now we're going to go to our plan. So whose part is it now to discuss your plan? Still Neddy?
Still my
Why are you the one
yeah.
again?
I was do the last part. You've done all the other people's part.
Oh, okay. All right.
Yeah.
So, Neddy, for your patient, given your diagnosis, again, it might be a little different from my diagnostics. Let's hear yours. Go ahead.
So CBC basic for want to see the white blood counts and differential diagnosis to determine this is to just help us confirm or help us to give us a rough estimate of is it bacterial or is it viral. So more of neutrophils we go for bacterial, more of lymphocytes and all that we go for viral. Next slide, Podok. And blood culture, growth, if we're really suspecting strep, we should be able to culture the bacteria. And strep usually has a characteristic, the colonies are small, gray, and they produce a green zone of hemolysis. So if this comes out positive, then it would help us confirm our diagnosis for S pneumonia. As compared to the next test,
Okay. But before we go to our next slide, Neddy, would you think that a specimen from the respiratory tract would be a better option than blood? Would
uh,
it be better to like do a swab or an oral one or maybe a deep suctioned aspirate? Would that be better?
We actually have that here, a swab.
Oh,
It's in one of the later slides.
oh, there. Okay.
Pharyngeal swabs or aspirate. We didn't. We ruled out sputum because sputum won't be good for a 5 months old. I don't know how you would be able to get sputum. So the nasopharyngeal swabs or aspirates. We could also use that to isolate other if the RSV, parainfluenza virus, and all that. This all these tests will just help us to confirm our diagnosis without the need for um, X-ray or any other CT scan or something that would expose the patient to radioactivity or any of that. So the CBC, the nasopharyngeal swab, the blood culture are top three tests.
Okay. But then again, come to think of it, Neddy, if you remember, your diagnosis says it's community acquired pneumonia, probably strep. So
Yes.
if you take a look at this slide, your slide is actually screening for mostly viral etiology. So how can you defend that? The
No.
quick answer is I'll answer my own question because
Okay.
I want to rule out the rest of the
Yes.
etiologies
Yes.
and it
Yes.
will strengthen my diagnosis should this
Yeah.
be negative. All right, so there you
Yes.
go. You were thinking on the right track again. So if someone asks you, "Oh, this is not part of your diagnosis," you should have just placed their bacterial, rule out viral. But then
Yeah.
again,
I tried to roll out the other.
okay, all right. So very good thing. So the management plan will also extend up until your specific and cognitive, supportive, and patient education. Go ahead, Neddy.
So for the management, I think the first thing we need to consider is, are we going to hospitalize this patient or not? So to consider for hospitalization, you have to take into account the age, the degree of respiratory distress. Is the patient vomiting, or is she able to tolerate oral fluids? So our patient meets all these criteria. She's less than 6 months old. She's in moderate respiratory distress. She's vomiting, and then she's already dehydrated, although not severe dehydration. But with these factors, would go ahead and hospitalize this patient. For,
I also like to point out I like how you said there was no response to appropriate
yeah,
antibiotic therapy. So mentioning that itself is already a good defense. All right, your next slide is all about the
the
antibiotic.
antibiotic to pick. So she has been treated before with other antibiotics, and none have really worked. But this slide is saying that the first thing you should do, the first treatment should be shouldn't you don't necessarily have to wait for your lab results to come out. You should start up with an empiric treatment. So the common empiric treatments based on the lab, based on what you're thinking, you have to think about the epidemiology of that area. What's their most common um, um, pathogens in that area? If they have more of resistance, strep pneumonia, or strep pneumonia that is susceptible, it would help us to pick a particular antibiotic to go with. So we can either go with ampicillin, Vanco, or macrolides. And you should continue the antibiotics for 72 hours till the fever breaks, and then it should stay for at least 10 days. Yeah. So here, I think the drug we're going with is a macrolide. No, ampicillin. We went with ampicillin and clindamycin. Yeah, clindamycin or ampicillin, one of the above. So
Okay.
I'm
I
also
think that's a good choice. Those are good choices, but I would definitely disagree with using your ampicillin or penicillin still. So remember that most of your
mhm,
strep that are resistant are not going to respond to your ampi or pen anymore. But there's a but there. And incidentally, for most of our patients in the hospital, in fact, some 7 days therapy will already do. So I highly encourage you guys to read up on the
mhm.
APP PCAP guidelines. So it's several pages and already a book almost, but it describes to you all of the classifications, treatment modalities, and the approach to your pneumonia patients. Okay, so I think I'm happy with your answer, Group 10A. So now we proceed to your general measures or supportive measures, I should
Okay,
say.
so in the treatment, during the general measures, we also have to consider the response to treatment. We have to remember that previously the patient has been refractory to the other treatments she has been given. So when we initiate the treatment of ampicillin and clindamycin, we should check with clinical and laboratory signs if there's improvement within that 48 to 72-hour period. And then how do we check? We could check with the current severity compared with how she came into the hospital and how is she right now. Is she progressing? Has she plateaued? Is she getting better, or is she getting worse? And then if we put all these things, if she's getting worse or there's no response, then we can go ahead with imaging to see, okay, what's the extent and how far is this progressing. And then we also have to remember that as much as, yeah, we've seen strep, if the lab results comes out and it says, oh, this is S strep, we should also test for resistance of the pathogen if we're still having refractory treatment. Yeah, that's basically the point of this slide. So you have to keep checking for response to your treatments. We did that 48 to 24, 72-hour window.
Okay, I agree. Definitely 72 hours. That's our magic number. Okay. So I think these slides describe your antibiotic choices depending on the suspected bacterial etiology. So it mentions group A strep, the strep pneumoniae, Staphylococcus aureus. So I am glad that you mentioned these. So congrats and kudos to you. So in fact, there are a few antibiotics here that are very hard to find. Linezolid is available in the Philippines, but the only patient I've used this on is a single patient about, I don't know, 10 years ago. We had to source our antibiotics from Manila, even. Okay, thank you for this one. So now it's time for you guys to see the supportive care. Go ahead, Neddy.
Um, the key here is you have to respond to the patient. The supportive care is all about what the patient that I don't there's no particular dictum here for us. It's just what is the patient experiencing and how can you support that. So we already know our patient is dehydrated, so we should give fluids. If the patient is already showing signs of respiratory distress, if it gets to a stage where she needs respiratory support, we can do that with supplemental oxygen, CPAP, or mechanical ventilation. And the vasoactive medications would also help for hypotension or sepsis if that would arise. Yes.
So, Neddy, you're describing the entire spectrum of respiratory support already here. My tip to you is stick to your actual patient. But make sure you know in the back of your head, because your consultant might be asking these questions, what steps will be next. So, all I'm saying is that if you remember our first slide, we were saying your plan is only dependent on how your assessment is. So if your patient is, in my case, the moderate respiratory distress, I might have enumerated this. If you diagnose it as mild, maybe your treatment is just by nasal cannula. That's fine. That's okay. So I would be careful about mentioning vasoactive medications right now because we haven't really established that your patient is hypotensive. So again, I need to know those treatment. Okay. Moving on to, I think this is your last
And
slide.
for yeah, this is the last slide. For further future prevention and patient education, would inform the parents to take up to give the child the influenza vaccine, and then because influenza vaccine has been shown to prevent pneumonia hospitalization among children. So for you can give for greater than 6 months of age and infants less than 6 months of age, immunization of patients, household contacts, and other primary caregivers. So the parents themselves should take up immunization since she's still less than 6 months old. And when she gets to that 6 months age, she should take her own influenza vaccine. Then maintenance of high rates of vaccination for H influenza type B, pertussis, and measles. significance. It has shown significance in the prevention of pneumonia from these causes. Then RSV specific monoclonal antibodies can be given. Then WHO and other international group, we should train mothers and local healthcare providers in recognizing and administering appropriate antibiotic treatments of pneumonia.
All right, very good. RSV specific monoclonal antibody is not available in the Philippines. So, short of that, maybe you would like to mention something that can boost the immune system of your patient. So, good nutrition, breastfeeding, use of vitamins, okay, good enough, specifically vitamin C and zinc. So, different sources will vary in terms of their recommendations, but suffice to know you want that end in mind, improved immune system. Next, the RSV specific monoclonal antibody, again, not available. So, your plan should be tailored to your patient. We can't give this yet to our patient. Not available. Incidentally, RSV is more common in patients who are born preterm and usually more common at the earlier months of life. 5 months, a little bit, not so much. That's not our primary concern anymore. Now, flu vaccine, unfortunately, we've had a lot of shortage this year. So if this were the situation that applied to that time, so February, it was actually hard to get vaccines during those months. So we didn't have vaccines until about April of that year. So in that case, your patient would have received it because your patient is already more than 6 months of age. So again, thank you for that, Neddy. So here goes my diagnostics naman. So as I told you a while ago, I'm going to let you see a preview of how I handled our case also. So for me, I would start with my diagnostics of SpO2 monitoring. So remember, your patient had a single SpO2 monitoring in the ER. It's important to monitor that. So still part of our diagnostics. CBC with differential, same is true with Neddy's explanation. Chest x-ray. Take note, guys, I'm specifying specifics in my views. So I'm saying chest x-ray APL, patient is not able to stand up yet. So the lying position would be best. Aside from that, take a lateral view for better visualization, especially on the retrocardiac area. So again, like Neddy said, it's not definitive, but some findings are suggestive of a bacterial versus a viral etiology. And you'll see later in the next picture I am going to show. It likewise also identifies consolidations, blebs, effusions, and other complications of the pneumonia. So just like you, I'd still like to do the blood culture and sensitivity. Sputum GSCS is really hard to do, but take note, if you really need to, you can nebulize your patient with hypertonic saline. So that what does that do? It makes your patient cough. So because of that, you can actually induce your patient to expectorate. So not exactly a pleasant thing or comfortable thing to do, but if you're pushed against the wall, you have to have a sputum GSCS. This is the way to do it. Will I do an RT-PCR for COVID-19? No. So this is February 2019. COVID has not yet entered into our health situation. So if I were your judge, I would definitely not consider this as a correct answer. So we don't screen for COVID. So guys, this is the bacterial pneumonia score. So it tells you if your patient is most likely suffering from a bacterial etiology. But take note, much of the scoring is based on clinical and laboratory basis, specifically and heavily on your chest x-ray. So we can't use this on our patient just yet because we don't have an x-ray taken, but this will be one of your um, rationale for taking a chest x-ray. All right. Definitive, I'd still start with low flow oxygen via nasal cannula. I want to maintain my SATs at 95% and higher. So take note, I'm actually enumerating figures because if you remember, doses is the scoring rubric item we are going to evaluate you on. So for me, it was a macrolide IV. So this time, I'm going to give azithromycin because I'm considering a typical etiology. But since in the back of my mind, I changed my mind right when Neddy was talking about her etiologies. I think it's still a strep, but a very resistant one at that. So take note, I'm be using exact doses: 76 milligrams IV OD for 3 days with the following doses and with the following guidelines, with guidelines also or advice for oral step down. And take note, I'm not using ampicillin per se, but ampi-sulbactam. Okay, so there you go. I'm still using my pen and ampi, but there's a partner to it. So that makes it more appropriate for your case at hand. So you don't necessarily put penicillin or ampicillin because probably they're all resistant to that. You'll try something else. All right. So, as a reminder, we must include the drug dosage, the name, and the route, generic name, preferable, and then must be PEDA appropriate, must be available and economical, and always consider shifting your meds to oral if they are already stable and can tolerate oral intake. So remember that part of my diagnosis was dehydration moderate. So here, it's justified for me to hydrate my patient at 5% deficit therapy with the following doses. Oh, you're saying, oh my gosh, such a headache. How am I going to compute for that? Nobody taught us how to do that. Well, okay, suffice to say, let's just say treat your patient with IV fluids for hydration at the appropriate levels for moderate dehydration. Okay, that's fine by me. You're going to know how to compute this much later in your clinical rotations. High back rest, something very supportive, very simple, but we'd still like to ask our parent to observe this. Steam inhalation, remember your patient had colds, but no findings. So maybe it's much, much deeper in the upper respiratory system, something that the saline inhalation can reach. So right now, I'm going to administer it via nebulization for faster and a more appropriate microscopic level of saline. So remember, I'm not administering salbutamol right now, but saline. So maybe you're asking, should we administer also salbutamol? Oh, yes, why not? So if you believe your patient needs it because your patient is wheezing, yes, I think we should have included it here. So even me, I forgot all about that until after I heard the history for a second time. Paracetamol, definitely you'll still need to offer this because your patient was febrile at admission. How much? This much. Education, pretty much the same as your group. And as our last slide for this afternoon, this is been, I hope, a very educational learning exercise for you. My last tips for you for this afternoon is that in order to establish your diagnosis, again, you must be able to defend it, and that your appropriate plan will always be dependent on correct diagnosis. Formulating the diagnosis that is easiest and, well, simplest is definitely the way to go. If it's better to account for one disease rather than many, that's also good. That's why I wanted to say that if you would stop your diagnosis from PCAP itself, that's still fine. The diagnosis again is based on the symptoms and clinical findings. That's your S and your O. Diagnosis must explain all, if not most, of the patient's clinical manifestations. You must also discover unexplained data and counter that by putting a number 2 to your problem list and explaining it separately. And of course, very important, keep your notes and references close at hand. So they're very important at this point because you're driving towards a diagnosis this time. So where you're headed is basically dependent on how much basis or database you can review and how those match against your diagnosis. All right. So I would like to say you did a great job this afternoon, guys. I would say it's pretty good. So you guys all deserve a round of applause. Yay! Sorry, Neddy was the major presenter for this afternoon. But nonetheless, I am glad to have seen all of you guys. And it seems that everyone is well. Yes, I think so. So I know that you have a lot of modules. Specifically, Dr. Tandok's modules are very information packed. Definitely, a lot of our patients are going to suffer from respiratory infections. So it's something that we would like for you to master for sure. Definitely. Okay. We have a couple of minutes. No, I have 1 minute to answer your questions. Do you have any? Do you have any clarifications that you would like to ask? None at the moment?
Ay, ma'am,
Yes. Yes, Kurt.
um, doon po sa for the ROS that does not apply to the pediatric patient, how do we write it?
Oh, for instance, you were considering the palpitations, right?
Yes po.
So definitely, it's so hard to ask your patient, "Are you having palpitations, Iha?" And the patient is 5 months old. So maybe we should have included that. Maybe you can say, if I feel that the patient is having palpitations, does this mean it's a hyperactive cardium? Maybe I can confirm this with my physical examination. So it doesn't become part of your ROS anymore, but in the part of the PE already. So what else? Reports of tinnitus. Well, we can never know if the patient is suffering from that. We can never ask, can never elicit it. So that's definitely something we can't put under any other part of your report anymore. So we remove it. Okay.
Okay po, ma'am.
All right. Thanks, Kurt, for your question. You're growing a goatee.
Ay,
Sige, I think it looks good on you. All right.
thank you, ma'am.
Okay. More questions from anyone else? It takes practice, by the way, guys, with regards to your defense, formulating your assessment, your plan. Again, the more practice, the more patients you see, the better you get. So it doesn't necessarily apply that, oh, it's my first exercise now, it's my first assignment, I'll get it. I'll have 100% correct output. Not always that way. Okay? All right? Yeah. So, Bettina,
Doc,
uh,
pwede po mag-photo ops.
yes, I was about to say that. Sige, mag-photo off na tayo. Bibilang ka na.
Doc, patanggal na lang po nung yung pine-present
Ay,
ko.
oo nga pala. Tanggalin natin si you are presenting and stop presenting. Yan.
Okay.
Alright, sige na tayo. Should we
One,
do
two, alin pa, Doc?
like this?
Sige po, I'll take several pictures so we can choose from them. Okay.
Two. Oh,
One,
sige.
two, wait lang. How do I do this? Okay, 1, 2, 3, smile. Okay, next one.
What's our next pose?
Um, kayo pa, Doc, what do you prefer?
Hindi
Sige
kasi
po, Doc, anything will
you
do.
have one free hand eh. Okay, peace sign.
Okay.
Can I
Yes,
have
with the
peace sign?
dog. Okay.
Oh,
1, 2, 3.
cheese.
Okay. Okay, last one.
Funny pose.
Okay, Doc. Okay. 1, 2, 3. Okay po. Okay na.
Okay. All right. So thank you everyone. You have a nice afternoon. Take care.
Yes po.
And
Thank you
until
po.
next time.
Bye
Bye.
po.
Take
Thank you
Bye
care.
po.
po. Thank you, Doc.
Thank you po,
Thank
Doc.
you everyone.
Be safe po.